Thanks for joining me today. My name is Mike Brusca. I'm a partner at Davis and Brusca, and my practice for quite some time now is specialized in nursing home neglect and abuse cases. And so today, what I want to talk about is bed sores. I would say bed sores are the most common claim I bring. Bed sores are almost always the result of neglect and are almost entirely preventable. So that's what I'd like to talk about today. But first, I want to start out with a little history. You may have heard of Florence Nightingale. Now, this was a really important woman. She lived like early 1800s. She died in the early 1900s. She was a genius. She was a British woman. She was a big social reformer. She was also a numbers person, a statistician, but she's also the founder of modern nursing. And she was early adopter on better hygiene, reducing infections, getting better outcomes that way. But she has a great quote apropos to our discussion today and about bed sores. It says, if he has a bed sore, it's generally not the fault of the disease, but of the nursing. And I got to tell you, that was true in 1859 when she said it, and it's true still today. So there's lots of terms to describe this condition, and when you hear them, they'll kind of indicate where I'm going to go today with my talk. Bed sores there's a Latin word decubitus, which I believe means lying down, but it's also referred to as skin breakdown, and they're also referred to as pressure injuries. And those last two terms, skin breakdown and pressure injuries, are, to my mind, the best terms to use when describing this condition, because they both give you the etiology, that is the cause, and also make it clear on how you prevent them. So what are bed sores? Well, skin breakdown is a good term because a lot of times this condition starts from irritation of the skin. Oftentimes, especially when people are incontinent, if they're not getting out of a soiled diapers quickly enough, then what happens is the urine and feces, which are agitators to the skin, will start to cause some skin irritation and inflammation. Now, if you've had kids, I have two, you're familiar with a condition called diaper rash. It happens, but ultimately it's easily reversible. And so but oftentimes, if you're in a neglectful environment like a nursing home where they don't have enough staff, these conditions that start out that are easily reversible get aggravated because they're not getting the proper care moving forward, and so the conditions get worse. So a lot of times, skin breakdown starts out that way. Now, it can also start out with what they call friction or shear. This is where a person is like sliding on the skin, all right? I don't know if they use Egyptian cotton in all nursing homes, but suffice to say, or in hospitals, the sheets can be a little rough or coarse, but just being dragged across something will also irritate or inflame the skin and can be the beginnings of skin breakdown. Again, though, those things are not unusual, and they're also easily reversible if the proper steps are taken moving forward. Now, the other term, pressure injury, is also key because sometimes you may not have incontinence issues with urine and feces. You may not have friction and shear, but you have pressure for too long in the same area. And the problem with this is that when you have pressure on an area that's not getting good blood flow, then that tissue is not getting oxygen. And normally it's the tissue right below the surface of the skin that starts to get damaged first. The skin is actually pretty tough, but the tissue below it is not. And so what happens is you start to get damage to the tissue directly below the skin, and that is the beginning of something that could be real problematic. Again, if you get these things early enough, usually it's reversible, okay? And so it's really important to understand that these are not foregone conclusions. There is a thing in medicine that's debated back and forth about, first of all, whether or not an unavoidable pressure injury even exist, or pressure sore, or if so, what percentage of them actually are. I would suggest to you that if this thing does exist, it's a very small percentage of the ones that occur. Okay, so that's what these things are, and that's what generally causes them. Now, pressure injuries, like other medical diagnoses, have stages, like cancer or something like that. Now, there's 4 main stages for pressure injuries, and then there's 2 other subcategories that are used within medicine. So if you have a loved one in a nursing home that's suffering from these, if you don't know these things and you're here, I'm super sorry about that. Right, it probably shouldn't be happening, but you usually become an expert in these conditions. So you have stage 1 pressure injuries, and this is a type of redness on the skin that's like sunburn. If you like to put pressure on it, it doesn't change the color of the skin, right? This is stage 1 pressure injury. It's an inflammation and damage to the skin that's showing up as a redness. Now, if you get a stage 1 pressure injury, you got to get the pressure off of it right away. You got to get some kind of barrier cream. Even the stuff that we use with kids, like A&D ointment or zinc oxide or something like that, something over the counter to keep it from water, moisture penetrating it onto the skin from urine or feces. You get that on there, that should clear up fairly quickly. If it doesn't get dealt with, you develop a stage 2 pressure injury. That is one where there's blistering on the skin. This is like diaper rash. It's red. There may be some open areas, maybe even some blood. But again, if it's just superficial, this is something that can be resolved fairly quickly. Usually aggressive offloading of pressure and a barrier cream to keep moisture from getting in there. Now, if it doesn't get dealt with further, you'll get a stage 3 wound. This is where the breakdown has moved into the body. The staging of these pressure injuries is based on the depth of the wound. So stage 2 is just skin deep, but a stage 3 is now below the skin. The most severe type of pressure injury is a stage 4 pressure injury. This is where the tissue damage is into the muscles below, it's into the underlying tissue. Oftentimes you'll see bone exposed, and it's very, very serious. Now, the other 2 subcategories are what's called an unstageable wound. Now, this designation is used when there's too much dead tissue in the wound to tell the depth. So you'll see unstageable. I will tell you, though, if it's an unstageable wound, by definition, this is a serious condition, right? This is maybe a stage 3, but probably a stage 4, right? And that dead tissue that's preventing a nurse or doctor from determining the depth is problematic oftentimes. So an unstageable ulcer is a very serious condition that needs to be dealt with. At least a doctor needs to know about it and have seen it. There's another type of injury called a deep tissue injury, or DTI. Now, these are a little different. So the types of injuries I've been discussing may start on a more superficial level, like the tissue just beneath the skin, and then blister, and then get worse until it's something serious. A DTI is where the damage is done, as the name indicates, deep, right? A deep tissue injury. And it'll usually show up as a very dark bruise. That's what it looks like. And these can be very, very serious because the damage below is already done. And if you do not have aggressive offloading, then what will happen is that will continue to get worse, and it will open up, and it will open up to something generally pretty bad. So DTIs are potentially very serious conditions. These are formed from just pressure, right? Unrelenting pressure. So the way these, people might have some experience with this, like if you've ever been hammering a nail and you hit your thumb and your thumb turns like almost a black color, that's a DTI, right? That's what you're looking at there. Or I'm a distance runner, so if you run like a half marathon or a marathon, and you'll see like one of your nails falls out, turns black, like that's a DTI, right? But because it doesn't have unrelenting pressure, it heals, right? It doesn't open up to something horrible and it heals. But when you have these on, say, your back, when you small your back or your buttocks or your heels, and they don't aggressively offload pressure, then they will open up to something usually very, very serious. Now, who's at risk of these are people that you would intuitively believe are, generally speaking, folks that are wheelchair bound, bed bound. They don't have a lot of mobility. If you look in a hospital chart or a nursing home chart, you will see something called a Braden scale. Now, the Braden scale was developed by a nurse, and it's a predictive tool for how good a chance there is of, or I don't want to say that, I would say the risk factors for developing a pressure injury. So there's a couple categories that are standard on these. They want to know sensory perception, right? Is the person you're looking at completely aware, or they, on the other end, are they completely non-responsive, right? They are also going to look at the moisture levels, whether they are continent, use the bathroom normally, or they're completely incontinent and in a diaper. The activity, right? Whether a person is mobile or they're bedfast, that is, they don't leave their bed, right? They're going to look at nutrition because there's a important link between getting enough of the right kind of food and preventing or healing skin breakdown. So they're going to look at that, whether it's excellent nutrition or very poor nutrition. And then they're going to look at friction and shear, right? How much of that's going on. Like if a person's bedbound and they have to be moved a lot, if they're a larger person, then the friction and shear might be greater. So they're going to look at those to see what is the risk of developing a pressure injury. And basically, this is a math formula. You get a score, and the score tells you whether you're low, medium, or high risk, right? And it's pretty intuitive, right? And the areas that these type of injuries develop are also intuitive. They're what they call in the nursing world bony prominences. These are areas where, by nature of the way the bodies and bones are designed, the bone is going to specifically put pressure in a specific area that could cause an issue. So a lot of times you'll see this in the buttocks and the small of the back because you have a bone structure there that is going to, if you're laying all the time, put pressure on that skin below it. And so that's a problematic area. The heels are a really problematic area because if a person, if they're not just picking the heels up periodically or offloading pressure, they're going to have constant pressure on the heels. The toes from the sheets laying on them all the time can be a problem. Rarely back of the head. I've had that a couple times. I have one of them now. That's extreme neglect in my opinion, but the shoulders also. So these areas, these bony prominences are pretty intuitive as to where you think the pressure is going to be a problem if you're not moved. Now, the steps to prevent pressure injuries are really basic. What should happen in any care environment is a new resident or patient is going to be assessed by a registered nurse. He or she will look at the Braden score. They're going to look at that person's history because if they've had a history of pressure injuries, that increases the risk of further pressure injuries because if you have a prior pressure injury, the skin is scar tissue and it doesn't have the same strength as regular skin. And so they're going to do that assessment and then they're going to generate a plan of care. Now, this, as Florence Nightingale indicated, is just basic nursing. It's keep people clean, keep them dry, and offload pressure, and that's it. And if those three things are done, the chances of developing skin breakdown go down exponentially, right? So how often do you need to offload pressure? It's a good question. And the answer to that is at a minimum, every 2 hours, weight needs to be shifted. Now, if you're sitting in a chair listening to this, I will tell you that you will do this automatically. Your brain knows to offload pressure. And so people shift their weight all the time without thinking about it. But if you are bedbound and you don't have good sensory perception, these folks need help to do it. In fact, there is a specific assessment for bed mobility in every nursing home residence chart to see, can they do this, or do they require assistance, or extensive assistance, or total dependence, and how many people are required to do that. That is a standard government document in every nursing home residence chart for bed mobility to do this assessment to be sure that it gets done, because this is a serious problem. And that's really how you prevent them. It's the basic nursing discussed by Florence Nightingale, and that's it. So if you're at my podcast because you're curious about this condition because a resident that you love has one, what can you do? All right, well, first of all, it's really important to intervene with these as quickly as possible. Any nurse will tell you it's easier to prevent a pressure injury than to heal a pressure injury. So if one starts to develop, getting on it as quickly as possible is really important. It's also important for other reasons. Anytime you have a large opening in the skin, it's what they would call a portal to an infection, right? Pressure injuries in and of themselves are not lethal. It's the fact that infection gets in there that becomes a real problem, right? Because our skin has a very important purpose. It protects us from infections, right? And if you don't have that protective layer, any bug that gets into that wound is now very, very dangerous. So when you have pressure injuries, especially in the buttocks or the small of the back, these become very problematic because oftentimes these folks are also incontinent, and if you get feces in there, that can be a serious, serious problem. And if they're not keeping it clean, so that can also be a very serious, serious problem. Or if they're not getting dead tissue out of it, because dead tissue also encourages infection. And so if you have this injury and you have continuing poor nursing care, these can be easily lethal. I have handled that case countless times, right? Countless times. So it's really key to intervene as quickly as possible. In fact, the standard of care is to notify a doctor and family member if there is any skin breakdown. I mean, even a stage 1, they need to call you and the doctor. They should call the doctor if it's a stage 2, so on and so forth. When you have a more serious wound, well, before I get to that, I would say this. When you have any skin breakdown, if you've been called by the nursing home, I think immediately I would call for a care conference. I've done another podcast on advocating for your loved one, and you can listen to that as to what to do. But a care conference is a meeting with all the heads of the caregivers for your person and ask them, what are we doing about this? Because they may tell you that this is a small thing, it's minor, should clear up in a couple of days. Yeah, I don't know about that. I would like to sit down with everyone and understand, what are we doing about this? What changes to the care plan are coming? How are we going to prevent this from getting any worse, right? Now, like I said, when the skin breakdown is in its early stages, usually a barrier cream is good enough to heal it, and aggressive offloading pressure, right? Some people ask, well, what about if you're in a wheelchair? What does that look like? Is it the same? I will tell you that generally speaking, the standard requires offloading pressure every hour in a wheelchair. And you can see why. If you're laying down, the pressure is more distributed. But if you're sitting down, the pressure is directly over top of the lower buttocks. They call it the ischial area based on the bones below it. So if you're in a wheelchair, you really should be shifting a resident's position at least every hour. And certainly if you start to see any kind of skin breakdown, you want to see the aggressive offloading every hour in a chair and every 2 hours in a bed at a minimum. I mean, they can do it more. They really can do it more. I will also tell you that in the pressure injury cases I've handled, I rarely see documented offloading pressure, especially by the people doing it. Because even if a nurse says, oh yeah, that was done, and checks it off, they're not the ones that do it. The ones who do the offloading pressure are the certified nurse aides. And that's really where the problems lie, when they understaff facilities, in particular with that role, and they just can't get it done. I mean, these CNAs are doing the toileting, the feeding, the grooming, the bathing, the dressing, and they just don't have enough of them to also make sure that they're doing the offloading pressure. It can be really difficult task when you have too much to do, and that's generally what happens. I don't think these people are psychopaths, but it clearly does not get done. And in my experience, that's why there's just not enough folks in the building to get it done. Once you have a stage 3 or 4 wound, now you're going to have dead tissue forming, and that can be a real problem. So this is dependent on the type of tissue that's in there, but oftentimes it needs to be cleaned out. So sometimes you'll hear of a chemical called Santyl, S-A-N-T-Y-L. This is like a paste. It's in a tube, and they're going to put it in the wound to a depth of nickel, like a nickel. They call it nickel thick, about that thickness, and then they use a solution to wash it out, and that strips out dead tissue, much like hydrogen peroxide would do. It's called a debriding agent, and debriding is the process of taking dead tissue out of a wound and keeping it clean. So you'll see that happening. You will see special bandages they put on these as they get worse that are required, but certainly they better be doing something, because a stage 3 wound, you absolutely do not want it to get to a stage 4 wound, right? Because at that point in time, any infection that gets in there is going to get in there deep. And oftentimes when you have stage 4 wounds, you also have what's a condition called osteomyelitis. That's where you have an infection in the bone, okay? So, and, you know, not good, right? Oftentimes, my cases result in death from what's called sepsis, where an infection from the wound goes into the bloodstream, and it's an overwhelming infection that an elderly sick person just can't overcome, and they die from that. So to this extent, you really have to be on it immediately. Of course, a stage 4 wound is very serious. The type of debriding they'll do there, sometimes they'll do what they call sharp debridement, where they use tweezers and scissors to take out dead tissue. They can do that for a stage 3 as well, but oftentimes the wound is so serious you have to see a plastic surgeon, and that's where they're going to get full surgical debridement, where you're going to have to go under anesthesia, and they're going to cut all into the living tissue all around it to be sure all the dead tissue's out. At that point in time, sometimes they can use what's called a wound vac, where they literally put a sponge into the wound, and they have a pump that pulls fluid out to keep any infection that might get in there to get sucked right out. Sometimes they can try to stitch it closed after a period of time, but it's very, very serious. And I will tell you that in my experience, elderly nursing home residents that suffer stage 4 wounds, they rarely recover. They rarely recover from it. They're very, very serious injuries. And usually the thing that makes me angry is that they were almost always preventable just by the basic nursing. So that's a crash course on pressure injuries. We talked about the different names, what causes them, and how you can prevent them. And certainly if you are listening to this podcast because your loved one has one, what you can do moving forward to hopefully help improve it or potentially heal it. So thanks for taking the time to listen to me, and have a great day.